going to get right to 18 months of sticking to it. Our team took over site care and we use gum mastic adhesive for vascular access dressing adherence. Again, I'm Elena, and these are my disclosures. I am a vascular access team specialist and team coordinator for NOCO Banner Health. I work per diem as a clinical educator for BD Bard and a consultant speak for Eliquis. What I'd like you to be able to do today is explain things as you need to with relationship between dressing integrity and risk of CLABSI. I'd like you to be able to review clinical outcomes that we've achieved using gum mastic adhesive with our central line dressings. And I'd really like you to be able to speak to the financial impact of adding gum mastic adhesive as you move forward and you consider using this product. I think it is important to be able to speak to all avenues of interest to everyone in your institution. We know that CLABSI is a zero event tolerance, and there's a good reason for that. When we were looking at ways that we could impact CLABSI beyond insertion, I looked at the last CLABSIs over a year period of time a few years ago that we had. There were 8 of them, and indeed 2 of our patients at our larger Northern Colorado facility did not survive their CLABSI. So that is right in line with what the literature says. And of course, current healthcare crisis accepted, Medicare, Medicaid are not reimbursing for nosocomial CLABSIs, and that estimate that I have there for you on the screen of $45,000 is from reading several different sources to come up with some sort of what I felt was an average CLABSI expense that is often the entire burden of the institution where nosocomial infection occurred. So we're at polling questions now. Blake?
One second here. All right. When is the risk of CVAD exposure to microorganisms the highest? So go ahead and select. What do you think? When the patient is immunocompromised with site disturbance or catheter entry, or when the patient is receiving care in the home? Just gonna leave that up for about 30 more seconds. Awesome. And 86% of people said with site disturbance or catheter entry.
And it kind of has to do with mnemonics. So I don't know why my camera keeps popping in front of my screen. That's weird. Okay, all right. And honestly, immunocompromised patients and patients in the home care may have increased risk factors, but truly you are going to have problems when something enters or disturbs the site. So if it was a trick question, y'all didn't fall for it. So vulnerability, when is site disturbance? Well, of course, with insertion, we're disturbing the site, we're creating the site. Catheter use, and if the dressing is disrupted unintentionally especially, but also even during our dressing changes where we intentionally remove the dressing. The first thing that I wanted to talk about briefly is insertion. There's been a lot of progress made on insertion. A lot of folks use checklists and validated observers. Almost everybody, if not everybody, uses maximal sterile barrier. And in fact, 2007 was the last year that we saw a CLABSI at any of our facilities in any of our vascular access team placed line that was even within 2 weeks of insertion. So the other point that I did that I have heard spoken about is the percent of time that insertion accounts for, and very conservatively, 1% of the time is the insertion in the entire life of the CVAD, and that is allowing 2 hours for insertion, and there's usually just an hour or less involved, and based on a 7-day dwell, which our middle facility, McKee Medical Center, has. At NCMC, our larger facility, most of our CVADs are in 9 to 10 days. We have a really good program also for avoiding placement of CVADs unless absolutely necessary. So truly, it's probably closer to 0.05%. So we've done a lot of work on this very short period of time. Then there's entering the catheter. So that's using the line. That's anything that disrupts that interluminal space. And we have policies about that, but there's a lot of opportunities to go off policy or to have an error in this area, changing the needleless adapter, flushing the catheter, giving medications, the amount of time you scrub or don't scrub. So there's some opportunity there potentially. And of course, with dressing integrity, because once that hole is in the skin and the catheter goes through it and into the vein, we have a slip and slide for microorganisms to get into the vein unless we put something over it. And again, we have policies around that. We say we want to keep a antimicrobial disc and a transparent membrane over our site for 7 days intact, and to change it if it is disrupted earlier. And that brings me to polling question number 2, Blake.
All right. Let's launch the poll here. So considering your current practice, where do you feel a change in practice would have the biggest impact in reducing CLABSI rates? Insertion, catheter entry or use, or site care and dressing practices?
And this is for you to think about for your institutions. There's no wrong answer.
All right. Looks like we're over 50%. Thank you guys for polling. And let's see here. Insertion was 3%, catheter entry 27%, and site care and dressing practices made up the most, 70%.
And that's probably in line with what we were thinking. I kind of prefaced what we've done for insertion and what's happened with insertion at our institutions. And we looked a little more specifically for Northern Colorado, and I definitely encourage anyone out there to look specifically for their area. And this is kind of what I came up with. Catheter entry. The vascular access team members, even though there are quite a few of us now compared to what there used to be, cannot possibly observe or actually perform every entry into that catheter. We can indirectly affect this possibly by partnering with education, teaching classes ourselves, and doing one-to-one teaching that we do, and we will continue to do that, but it is still an indirect effect. However, when we think about dressings, it is possible that we have enough coverage. We now have 24-hour coverage, and we've done some things with coverage for us to take over routine site care. So in the past, when we were first thinking about doing something to improve our CLABSI numbers, we knew we could probably do this with some creative staffing that we subsequently accomplished. But can we improve outcomes? So now we want to know a little more about dressing disruption. So when a dressing comes off prematurely, is this a cause of CLABSI? Well, there's been a multi-center randomized study that says, yes, there are some pretty big increasing issues the more disruptions you have, and even site colonization issues, the more disruptions you have. So not only do we hypothesize it, but there is a study, a review study showing us that this happens. So next we have to say, all right, if the dressing comes off prematurely, it's a problem. How do we fix that? So went back to the literature and looked for something we could use to help us fix this. And this was all probably going on when we first started around second quarter 2018, and we found a couple of current articles, studies that gave us our direction. One was from Shelley DeVries, who was able to keep 93% of her dressings on with her team using a gum mastic adhesive. And so my next question is, what does that do to my site disinfectant? And the same year, we had a study from Ryder and Dully showing us that skin disinfectant is not affected when gum mastic adhesive is applied over it. And then probably the thing that helped this happen for us is that we did have access already to medical grade sterile gum mastic adhesive. I had to special order it, but it was in place in our organization, which was helpful, which made things quicker for us. So now we have a question, right? Are we going to be able to do this? Can we reproduce results? And does it do anything to our CLABSI? So the nuts and bolts of what we did is we ordered a box of gum mastic adhesive. There were 48 ampules in this particular box. So we found 33 patients that we could dedicate all of their site care, from insertion to time to go home and line removal or sending them out the door with their line, that we could use gum mastic adhesive on throughout their stay. And that is what we did. And then at the same time, there were other patients in the hospital that had standard CVAD site care. And I performed a 20 chart review of those patients to have a control population, and then we compared. We did not have any dressing disruptions, even partial, among our 33 patients. And I guess I should explain what we were considering partial was a dressing that lifted enough. We have a gauze border on our dressing, and it would have been a dressing that lifted enough beyond just the very edge, just a tiny little bit of the edge curling up. Anything that lifted into the gauze border was considered partial, and anything that even pigeonholed down to the site is considered complete for us. Now, in those 20 control patients, and this is what was documented in the chart, and we have found in the past that not all early dressings get charted unless we're the ones doing them. 7 of those patients lost their dressing. That was 35% of this group. So we had 0 versus 35%. It is important to note that neither patient in either group developed a CLABSI, and that probably had a lot to do with the fact that this particular institution, we have a fairly large institution in Northern Colorado, and then a couple of fairly small ones. One's really tiny and the other's just small. And we did it at our middle facility, or McKee, and they hadn't had a CLABSI problem in a long time. So now we're looking at, hey, everything sticking is way better than a third of them coming off, but we didn't have any CLABSI, so there's no way to answer that question. So I'm trying to decide, do I do a larger trial? Do I bring it over to the big facility and do a larger trial? Do we just implement, or do we just forget about gum mastic adhesive and continue what we were doing because nobody had a CLABSI? And at that point, the manager part of me kicked in and said, what other things do I want to know to continue this trial? And I think this brings us to the next polling question. Yes, Blake, if you would, please, sir.
Coming right up. All right. So beyond improving patient outcomes, what else is of most value to the healthcare industry? Is that reducing supply costs, reducing labor costs, or recoverable nursing time? Looking pretty good so far. Just a little bit longer, guys. All right, let's close that poll. So the results here, reducing supply costs made the most, 51%, followed by recovering nursing time, 39%, and reducing labor costs, 11%.
So this question was kind of asked just because I was interested. I actually looked at all 3 of these things because I thought they were all 3 important and all things that I could speak to my supervisor and say, hey, here's what we're achieving, we're going to do this thing, or here's what we're not achieving, we're going to let this go. First, I looked at supply cost, and a fortunate thing of choosing McKee Medical Center is the average inpatient CVAD dwell there is 7 days. So if you needed an additional dressing change, it was likely an additional dressing, so additional supplies. So based on that, 7 supply kits cost us about $9 each, that's $63. Had we placed gum mastic adhesive under the dressings for all 20 of those control patients, and this is all 20, not just the 7 that disrupted, it would have cost about $27. So up to 67% of supply costs for this particular small procedure, dressing changes, but important procedure that we do at the facility, are potentially recuperable. So then the other thing I said, well, okay, we got really lucky and we didn't have to early change any of our 33 patients' dressings, but that probably will not happen if we do a bigger trial. So where am I going to break even at on supply costs? And that was around if 4 of those 7 dressings had still disrupted and had to have an early dressing change with gum mastic, we would have broke even as to using it versus not using it and have 7 disrupt, if that makes sense. So then, because I was doing a presentation on this, I went with some national statistics, and the average cost to staff a registered nurse per hour over across the nation in 2018 was $55.27, and I'm sure that includes benefits, etc. So a dressing change, if you do everything correctly, you've got to get your supplies, you've got to wash your hands, you've got to prepare the patients, etc. I think 15 minutes is a very reasonable amount of time to allow for this, considering all components through documentation. So that's about $14, a fourth of that 55. Gum mastic adhesive application takes about a minute to do. It's going to add a minute to the procedure, so there's another buck. Doing the math, this meant 7 dressings cost in nursing labor dollars about $100, and it would have been close to about 20 to use gum mastic adhesive, again, on all 20 of those control patients, or even 49 for all 53 patients, because we did use it on those 33 patients. So looking at that per dressing, using it on all comers, you still have the cost in nursing labor, 49 versus 97 roughly. With, I don't know why I said time is a little more complicated to quantify. It is math. So 240 hours is 4 hours of site care for 20 patients. You get an extra hour and 45 minutes or 105 minutes when you do those 7 extra dressings. So you get 345 minutes. You've increased your procedure using gum mastic adhesive by a minute for all patients. So instead of 240 minutes to do those original 20 dressings, you have 260. And so looking at the difference percentage-wise on time between 345 minutes with those extra dressings and 260 for all those dressings to go on and adhere the whole time, we could save as high as 25% of time. So anytime you can tell a nurse, here's 25% of your time back, even on one little thing, I think they will find something very clinical and very appropriate to do with that time. A simpler way of looking at it, and what I put on the graph next time, is every time each patient that had to have twice as many dressings as they should have had, which was the case for all 7 of those patients, nursing time was doubled doing that particular task. And then just because we all like them, we put it on the bar graph so that we could really see it before and with the product. So that kind of helped me make the decision as to what to do. We went ahead and fully implemented, but before I get to that, I'm getting a little ahead of myself, I apologize. Did we reproduce improved dressing adherence? Oh, yes, we did. Was it through use of gum mastic adhesives in particular? Yes, it was. And we still don't know about reducing the risk or the incidence of CLABSI from this early trial, but we didn't disprove that hypothesis either. So we moved forward, and on January 1st of 2019, McKee Medical Center and Banner Fort Collins Medical Center, our two smaller facilities, we began doing site care and daily rounds. We began doing site care at North Colorado Medical Center, the larger facility, in February, because I had to do some creative staffing to get that accomplished there, where we had a lot more lines. We round on every patient, and ones that are disrupted or ones that are due, we change the dressing and we apply gum mastic adhesive most of the time to most patients. There's obviously a couple of variables here because we now have experts doing lines. And the other thing we do is an audit of other metrics that have to do more with lumen entry, and I will get to that later on. And of course, I have been working with infection prevention for years. We drill down on every CLABSI we have, and that process continues. So here we are today in May of 2020. Is gum mastic adhesive still holding, still keeping our dressings from disrupting compared to not using it? Yes. However, there has been this little thing called the coronavirus that has come along and changed healthcare temporarily as we know it, and it actually did impact what we do at the bedside a little bit. Prior to the current healthcare crisis, we were daily rounding on every single patient that had a central line. We did see a few disruptions, so we did not maintain that zero, which I anticipated. Most of our disruptions are partial, and most of our disruptions are actually with new provider placed lines, and they do not yet have access to the gum mastic adhesive. We are still having to special order that. And most of those partial disruptions are occurring on high neck IJ placements. Now, if a line is bleeding, and we do occasionally see oozing from lines, it's usually with our very, very large bore HD catheters. Even if there's gum mastic adhesive on the site, there's usually at least partial disruption before we can get there and do what we do to control the bleeding. However, the most important thing, the thing to take away is our CLABSI rate plummeted from 5 in a year period of time down to 1 at our large facility with the use of gum mastic adhesive. Now, since early April, we have not been doing rounding on COVID-19 patients. This was due to a lot of panic and fear, to be quite honest, by our ICU staff, and they asked that we not use their PPE just to go in the room and look at the line and come back out. Our physicians said, we don't want any CLABSI, so we still want you doing site care. So we do go in when site care is due and actually physically be in the room and do the site care. However, there has been, fear does weird things to people, and many of our critical care nurses will preemptively change the patient's dressing instead of calling us. They don't want us going in there and using their PPE for that. Plus, I also honestly think there's been a lot of confusion between us not rounding, but us still doing site care versus maybe we're not doing anything, and they want to be good stewards to their patients. So what I decided to do to see, okay, here's another chance, another opportunity for me to see what gum mastic adhesive is doing. So on May 4th, I audited our charts. We have a pretty easy way to find out who all has central lines in our facilities. And at NCMC, we had 30 inpatients that had central lines of some kind. 47 lines had been in these patients at one time or another. 13 on May 4th had already been discontinued, and these 30 patients, between them, had 34 active lines. The 4 extra lines were HD catheters in addition to central venous access for other purposes. Those total days were 419, and they represented 86 dressings. And weirdly enough, 43 were performed by our team, and 43 dressings were placed either by the bedside nurse or possibly by a provider at insertion. Although usually at insertion, what happens is they stitch down their line. Yes, they still stitch down their line and walk away, and the nurse dresses it. But gum mastic adhesive, again, unfortunately, is not available to other staff at this point. 27 dressings out of this group came due early. So then I went back and I looked at who applied these dressings in the first place, the ones that came due early and had to be changed due to disruption. 4 of the 43 dressings placed with gum mastic adhesive, or 9.3%, 10 per 1,000 catheter days, if you will, had to be redressed sooner than the 7 days because of disruption. However, 23 of the other dressings had to be changed early out of 43. That's 53.5%, or 55 per 1,000 catheter days. Now, 8 of these dressings I almost consider outliers. There was persistent bleeding at these sites. Part of the problem is, whether to count them or not, is we were not called for this bleeding, and we're supposed to be called for this bleeding. They were both HD catheters. Usually when we have a persistent bleed, it is in an HD catheter. And the bedside nurse changed those dressings 4 times each on those 2 CVAD sites. So if I take those out, we still have 42%, which is still way more than 9.3%. So on the next slide, I'm just going to show you the graph. So I did all the math again, and I put it on the graph again. So it's that same nursing time, nursing dollars, supply expense, and dressing lots. Please note that because the scale on the left-hand side is so large due to expressing the dollars and the minutes and the amount of minutes, I had to have a 1,200 total. I did multiply the dressing loss by 10 just so you could read it. So it's really 53.5% and 9.3%, but I wanted it to be very visible, the difference between the two on the graph. But this is that same graph, and as you can see, without gum mastic adhesive, everything is increased. And please keep in mind, just as before, I included the increased expense of buying gum mastic adhesive and that additional minute of time for the dressing care with gum mastic adhesive, and we still have savings across the board. So here's the big question. I'm one of 2 questions I'm interested in knowing what you think about, Blake.
All right, here we go. So what do you think happened with our CLABSI rates before and after the COVID-19 crisis? Is it down prior and back up with COVID? Down prior, stayed down with COVID, or no change before or during the COVID pandemic? That's really good participation today on these polls. Just a couple more and we'll close this. Awesome. And we'll say it's, well, I'm not going to say completely split down the middle because there's 3 questions, but so it looks like the most people thought it was down prior to, so with all the hard work you did, and then back up during the COVID pandemic. And then the no change was the second highest, and down and still down with COVID, 24%.
So it's on the bottom on this next slide, but the title is CLABSI is the lowest it's ever been. And I put whisper because you know how we don't say the Q word, we don't say the CLABSI associated with no or zero loudly. But in 2020, this entire year, we have had no CLABSIs, including our COVID patients. So the ones above that I talk about are what we had, what we saw in 2019. So I don't know for sure if NICU patients count for CMMS. I do know none of the others count for CMMS when we're being, when our reimbursement is being held, are not given when we have a CLABSI. But I still wanted you to know this is what we've seen. It doesn't, if just because it doesn't count against us for reimbursement for value-based purchasing doesn't mean it doesn't count for the person who develops CLABSI. So that first CLABSI was really frustrating to all of us. This is a very, very non-compliant patient. You can read what all happened. The good news was our team, this was actually at McKee Medical Center, so all those years of no CLABSI were lost with this CLABSI that occurred. I don't think there's a whole lot of things we could have done to prevent that. We did have very good documentation because we saw him every day and tried to convince him to let us do what we needed to do for him, and he just would not permit it. The one CLABSI in here, the second one happened, I think, around August, and just there was no obvious reason that the CLABSI occurred. So it happened. It just happened. And then the third one was on an umbilical catheter on a neonate. We actually, the NICU staff does their site care, and we don't use gum mastic adhesive on them. Most of you probably know that care for neonates is very different. And so, but we did, that was a CLABSI that we had, so I put it on here. So at this point, we're approaching, if you look time period to time period, 90% at our largest facilities. Keep in mind that our small facilities really don't have CLABSI, and so I put nearly on there because the non-compliant patient situation did occur. So what do we have to do now? We need to find new ways to approach these non-compliant patients. Ultimately, what happened with this guy is he wouldn't comply with anything, and he ended up leaving the hospital early because he wouldn't let anyone do anything for him. But it would be nice to, at the minimum for our team, find a way to get that site care performed or get the line out, and at best for the patient themselves, get them to understand that compliance is going to make their outcomes the very best they can be. We did revise the neonatal skin-to-skin practice. They do feel like, looking at the drill down on that case, that was the chance for contamination of that umbilical cord catheter. So that has been revised at our institution, and there's a barrier between that catheter and the patients when they do skin-to-skin. And of course, here very, very soon, we want to resume our rounds on all patients. Our COVID census has dramatically decreased, so I do see that happening by June for sure, that we can round on everyone, including patients that we need to put PPE on for. So this, now I am kind of interested in what you think here, because you guys are experts. Why didn't we get a CLABSI in those 23 lines that disrupted like they did? The bleeding lines, was it pure dumb luck that we just didn't monitor for them? Or was it the influence of the team? Oh, I'm sorry, Blake, you were supposed to do that. I apologize.
You led right into it. It was perfect.
This is the one that I'm just curious, because I really don't know the answer to this.
Yeah,
I know it's not.
So yeah, the three questions for you guys again: just pure dumb luck, insufficient monitoring, or influence of the vascular access team daily rounding and site care. What was the biggest reason? I love it. There's some good results. All right, I'm gonna close the poll. Thank you guys. And 67% influence of the vascular access team, daily rounding and site care, followed by. Yep.
Go ahead. I'm sorry.
No. Insufficient monitoring for CLABSI, and then the pure dumb luck was the lowest at 11%. So.
Okay. Well, one thing I can tell you before I go on to the next slide is that it was not insufficient monitoring. Our infection preventionists did not drop their diligence in searching for CLABSI. So that I know it wasn't. They are very diligent. They even help us look for peripheral line-associated bloodstream infections. So I feel that the odds of it being that are extremely low. But I agree with the 67%, even though there's no sure way to know. We exemplified site care for over a year pre the crisis. We're reviewing those other factors that I'm going to talk about very soon, and we are giving them one-to-one, just-in-time nursing education when we catch something in the room that perhaps they didn't know they needed to do, or that they just forgot to do, or it didn't happen because of shift change, whatever reason. It is harder to let things slide when you're used to being watched. So I think if time went on, the influence that we've had would wane, but I do think that it is the influence we've had. And I think part of what leans me towards that is the fact that there was never overdue site care for any of these patients. So we either got in there and did it when it was due, or the nurse preempted us and did it when it disrupted or when it was due, before we could get in there. So here's that variable that I mentioned that I think is like super important, and that is what we do when we round. And every day we round on every central line patient, COVID patients accepted for a little bit longer. And we look for factors other than just the dressing. We look for the caps and the tips being where they're supposed to be, when they're supposed to be there. We check the date labels, and if it's not there or the date is expired, we bring that to the nurse's attention, and then we check that the CVAD lumens are clamped when they're not in use. And again, anything that is not correct, we either correct and then tell the nurse we did it, or we notify the bedside nurse to go ahead and get in there and get that done as soon as they possibly can. And we also send these elements in for formal auditing to our QI department. There's actually a form that we complete. I have that form on the next page. So if you guys want to take it and build something out of it and not reinvent the wheel or use it, you totally can. We don't do a paper audit on every patient because we do quite a few site rounds every day. We have a population anywhere from at a low 20 central line patients in our facility to way up in the 60s with the COVID-19 crisis. So we only fill out the form when we actually perform a dressing change, whether it's a due or it's an early dressing change. The other thing I need to tell you now before I forget is we have not been doing those paper audits since early April, and that's because we were designated as the line team at that point for our COVID patients. We upstaffed, and I felt like we needed to focus. We could still do the audits unofficially, tell the nurses when there's a problem, but we needed to be available for lines when they were needed to back up our doctors, our providers, and our patients. There's our form. It's pretty simple. We turn it in. I will tell you, it has patient RN on there. I often leave that part blank, but I think it is good that we have the unit, and the person doing the rounding, especially, or the room number, and then they can tie it back to the unit. Like I said, you can use this document if you want. I had to put bars over brand names because a lot of us know our caps by their brand names, for example. But I think it's pretty understandable even with those things covered. And about 2.5 weeks ago, I got back some bar graft results. It was a little early to talk about it today, but what I'm seeing in general is we know from our rounds that people are not writing the dates on dressings when a provider puts a line in, whether it's the provider that puts the dressing on and doesn't do it, or the bedside nurse that doesn't do it. So we know that's happening. Dated dressings, if it's a new site, it's probably not dated unless we did it. Overall, with the exception of ICU, all those elements that I talked about monitoring for have improved in all of our areas. This is comparing 2019, June, December to January, early April, when we stopped doing the paper audits, 2020. For some reason, ICU slipped in that first quarter of 2020. I don't know why, but they actually did a really good job to begin with, I was actually impressed by, and again, I'm talking about our large facility at this point, by how well they did when we started doing these paper audits, and for something happened and things kind of slipped there. But everybody else has actually improved quite a bit. We have only been we have been using gum mastic adhesive since before June of last year. So we haven't seen a whole lot of change in the likelihood of whether the dressing is intact or not. Now, unit to unit specific, that's a little different, but when you clump them all together, there's not a really statistically significant difference. That probably means that dressings that disrupt, whether there's gum mastic adhesive present or not, disrupt about the same amount of the time, all the time, which is probably not that terribly surprising when you're looking at all comers. I did put an example of a line graph that I did with one of our units, our step down unit, on this page, just so you could kind of see how I laid it out in case it would be something interesting to you. And you can see that the orange bar for 2020 is above the blue bar for 2019. And when I originally did this audit, in the Excel spreadsheet that QI sent me, they came up with blue and orange. And I was like, oh, good, it's Colorado, it's Bronco colors. And when I transferred it to this PowerPoint, it changed colors. So I totally had to change it back because all of the Bronco fans just would not have it any other way. And as my boyfriend says, what do you care? You're not really a football watcher. So maybe I should have made it the colors of the Colorado Rockies, because I'm a baseball fan myself. So one other thing that I want to touch on is we have used a lot of gum mastic adhesive. So what happens with it? And the first thing people think of is medical adhesive related skin injury, or MARSI. We have seen very little of that. So let me tell you what I think about when or when not to use it. When skin is very thin, we tend to use an alcohol pad or adhesive remover to lift the dressing, with or without gum mastic adhesive. So that helps a lot. We take our time. We don't rush ourselves through dressing changes. So we take the time to attend to the skin. If there is a lot of very superficial edema under thin skin, I tend not to put on gum mastic adhesive. It's almost impossible to keep that skin intact sometimes, even with a dressing that doesn't stick well. So we have seen skin tears in those type of situations, and we did have a skin tear on a patient when we were taking off the securement device, but typically we don't put gum mastic adhesive under the securement device. On occasions when I think it needs extra stickiness, I do, but our securement device is already very, very, very sticky, so most of us don't put the gum mastic adhesive under there, just where the borders of the dressing are going to go. We've seen some irritation when you're taking off the dressing, no matter how careful you are. There's been a couple patients I saw a bunch of little red bumps come up, and on those two patients, I decided not to reapply gum mastic adhesive in case it was some sort of weird allergic reaction that only occurred when I took the dressing off. And so I just chose, it wasn't that generalized erythema that you usually see when you pull a dressing off maybe too fast or on super sensitive skin. There was little red bumps, but I didn't see them when I walked up to the patient and I looked at the dressing before I started taking it off. So I don't know if that was just a reaction to something sticky being pulled off the skin, probably. Let's see. We have had, I talked to Seth, my team member who got this whole study going in the first place. I talked to everybody before I came here because I wanted to make sure I wasn't missing anything. And he says that when we have a dressing on a patient who then subsequently becomes very edematous in a short period of time, the gum mastic adhesive holds the dressing to that skin, and sometimes you have tension between the edge of the dressing and the skin that is not covered outside of the dressing, and trying to get that dressing off, he's had a few small skin tears. So based on that, if we're expecting a very sudden onset generalized edema, we may choose to leave gum mastic adhesive out from underneath the dressing until that edema kind of plateaus. And so my example for that is we do have a burn center at our large facility, so our burn patients If we see that there's been some swelling that was unpredictable happen, we will take that dressing off. If it looks like it's straining the skin, and replace it, just to let the skin sort of do what it needs to do to stretch out and accommodate that edema. Haven't seen any allergies other than that weird bumpy thing, which I don't know if it was an allergy a couple of times. I know that that's possible, and I've heard of them, but we haven't seen any at our 3 facilities. There are some people that don't like the odor of gum mastic adhesive. Some patients don't care for it. Most patients actually find it pleasant or just ignore it. And it does seem like once the gum mastic adhesive dries and we put the dressing on, the ones that kind of grimace or kind of go make little funny, I don't like that smell noises, are fine after that. And nobody has said, oh, don't put that stuff on because of the odor or anything else. Again, we don't put gum mastic adhesive below our sutureless securement device very often because it is a very sticky one. So only if I think I need extra stickiness do I put gum mastic under there. And we don't put it underneath where the antimicrobial disc goes. You basically use it on the outer edge where the outer edge of the dressing goes, and kind of have that little window where the, and I'm talking with my hands and you can't see them, where the the antimicrobial patch and the securement device goes. We don't typically paint the gum mastic adhesive on there. So it never ends, right? So I included our next steps here. I don't know how important they are to you, but we do need to get gum mastic adhesive in our central line dressing change kit, or at least get it available to our providers so that it's put on every single time, whether it's us placing the line and applying the dressing or someone else. I think it has proven itself. I think our outcomes show that. So that is something that I'm trying to time with when the components of our dressing change kits are allowed to change. We are a very large organization, and sometimes the wheels of that organization grind very slowly. We're going to present our audit findings at Nursing Leadership Council. We're going to talk about the value of the vascular access team, placing the dressings, using gum mastic adhesive. We're going to celebrate those outcomes that I'm seeing prematurely with the audits across the hospital in our general inpatient units, where they're keeping their patients' points of catheter entry safer by using their caps and tips and not hanging and attaching expired tubing. We'll talk about opportunities in our ICU from the little bit of drop that we've seen this year. And I really want to talk to our General Nursing Leadership Council regarding the 8 dressings for those 2 patients that were oozing, because honestly, I do not feel those dressings would have become that wet. I think if they had consulted us, which is something that they it is something we ask them to do when they have complications, to consult us whether we put in the line or not. We have hemostatic powder, we'll use pressure, we'll use hemostatic gauze, all kinds of things to seal the site. And actually, I've had a couple of instances in the last little over a year where I've had to refer my patient back to the provider because I suspect they had a venous tear with HD catheters going in, and we just could not get the bleeding to stop. But we pick up on that a lot quicker than the general nurse does. And I think I might be about there. Yes, those are my references. I think they're referred to on each slide, but I put them all here together for you as well. And then these are my teammates. The original group of us is in the corner because we would not be where we are without them. And we would not be where we are and where we're going without this large group of people to the right there. And I appreciate them as much as I appreciate all of you. I appreciate your attention. I thank you for everything you do for patients. If I can help you in some way, there's my email address there at Banner Health. You're very welcome to email me. I speak a lot on the Vascular Access Specialist Infusion forum on Facebook, so you can get a hold of me that way too. And if you have any questions, I think we're there.